We're now live on Facebook. Welcome, everybody. Okay. Adesua.
All right.
Yes.
We're good. All right. So good evening, everyone. Hello. My name is Adesua Watson, and I bring you greetings as one of the co-chairs of the Suffolk County Multicultural Advisory Committee, also known as the MAC. We are so grateful that you are joining us this evening for our virtual symposium entitled Cultural Humility in Behavioral Health. Tonight's discussion, which is in partnership with the Suffolk County Division of Community Mental Hygiene, is in recognition of Mental Health Awareness Week. And this discussion seeks to illuminate the impact that racism, bias, and privilege have on the provision and continuity of mental health care and substance use treatment. So before we dive into the meat of the program, I'd love to give you a little bit of information about the MAC and its mission. The mission of the Suffolk County MAC is to advise the New York State Office of Mental Health and the Suffolk County Department of Health Services, Division of Community Mental Hygiene on policies, programs, activities regarding service provision to individuals with mental health or emotional challenges who are from diverse racial and ethnic backgrounds. Our goal is to tear down barriers to recovery, such as disparities in access to treatment, lack of access to quality services, lack of information, language difficulties, stigma, mistrust, bias, prejudices, and discrimination. We promote culturally, linguistically, and spiritually competent services, enhancing the value system that sees recovery and optimal health as achievable for every person who has experienced mental illness. The MAC is comprised of representatives from several service-based and mental health agencies throughout the county. As MAC members, we have a shared goal to address distinct needs of and advocate on behalf of our diverse communities. So with that being said, before I get to introducing our moderators, I'd like to pass the floor to my fellow co-chair, Anne-Marie Montijo, to share a few words.
Thank you, Adesua. I'd like to just welcome everybody today. This topic of cultural humility is finally getting some traction, finally getting some play, and the work that we do in Suffolk County, it's imperative that we become much more culturally aware and recognize our own implicit bias. And hopefully today will be one of the first steps some of you are taking to learn about that. I want to thank our panelists. I want to thank everybody for joining us. Thank those that are watching on Facebook. And hopefully we'll be able to get this video out to the different agencies so that they can use it as a starting point for discussion within their organization. Thank you.
Thank you, Anne-Marie. So let's introduce our moderators for the evening. We have two moderators, Ariel Kaufman and Olga El-Fahemy. Ariel is a social worker and the compliance officer at CN Guidance and Counseling Services, which is a certified community behavioral health center on Long Island. She is also current board president of NAMI New York State and a Suffolk County MAC member. Olga is Suffolk County's director of the Division of Human Services, which encompasses the offices of Women's Services, Minority Affairs, People with Disabilities, and the Youth Bureau. Olga has also previously served as our co-chair of the MAC. Ladies?
Thank you for welcoming us here today. So I think that Olga is actually going to move forward with the introductions for our first presenter.
Thank you very much. Someone who needs no introduction, but I will introduce him because I am very proud to work for him and be part of his administration, our Suffolk County Executive, Steve Bellone.
Olga, thank you very much. Really appreciate the introduction, and it's an honor and a privilege to work with you. Thank you for everyone who is on the call. Thank you for the amazing work that you do. I want to thank the Multicultural Advisory Board on mental health, the Division of Mental Hygiene, Anne-Marie Sordi, our director, who is on the call. I don't see right now, but I know is on the call, and the Office of Minority Health as well in Suffolk County. So we are 7 months now into this pandemic. It's hard to believe. But back in March, we were having our first case March 9th. And within days of that, we're shutting down our schools and going up this mountain where we didn't know where the peak was. And coming down the mountain, we've been able to keep our numbers down. We've been now 6 months after able to reopen our schools, continue to keep those numbers down. But we were the epicenter in our nation and for a time in the world. And we really have seen both extraordinary acts of selflessness and courage and bravery, and also incredible pain and trauma and anguish throughout this pandemic. And we know we're not done. We are still in the midst of the battle against COVID-19. It has not gone away. It will be with us here into 2021 and maybe through 2021. We all hope and pray that there will be a pathway, therapeutic treatments, vaccines to get us past. But we know we're going to be living with this for some time. And we have only just begun to grapple with the impacts from this. I don't think we're going to be able to fully understand what the impacts will be ultimately for some time. This pandemic has produced multiple crises, an economic crisis, a fiscal crisis, of course, the public health crises and human services and social services crises. But what is clear is the mental health crisis that this has produced. Never before have we experienced across our society this level of social isolation, where our kids are away from their peers for long periods of time, where seniors are isolated, where we had families who weren't able to be with loved ones when they were dying in hospitals, people who were alone, without friends or family around them. Absolutely devastating. And there's no one who has not been impacted in some way by this. And as I said, will not fully understand or comprehend this, I think, the full extent of it for some time. But we know that this is a transformational moment in our society, without question. And that's why our comprehensive behavioral health care provider network has been pivotal in helping people make their way through this, and will be critical moving forward for a long time to come. But what we do know, as is the case in healthcare generally, that there are disparities in our understanding of the differences in culturally diverse communities, and that creates disparities as we see all across healthcare, and it certainly is the case here. And that's really the purpose of this call. That's the purpose of this conversation, because it is absolutely vital that those disparities and that at times lack of understanding of cultural differences and a lack of cultural competency does not interfere with the delivery of the care that is needed, and does not prevent people from coming forward to get the care that they need. This is a profoundly important issue that we have to grapple with, and we will be dealing with for some time. So I really do want to thank everyone on the call once again. Again, particularly the Multicultural Advisory Board on Mental Health for putting this together, for your work in this area. And I thank everyone for what you're doing. And I look forward to continuing this conversation and this work with everyone. Thank you very much.
Thank you.
Thank you, County Executive. And now I am going to introduce Anne-Marie Sordi. Anne-Marie is Director of Suffolk County Division of Community Mental Hygiene under the county's Department of Health. Anne-Marie is a tireless advocate. She has advocated providing mental resources for mental illness and substance abuse. Anne-Marie Sordi.
Thank you, Olga. Good evening, everyone, and welcome. I wanted to say welcome to this evening's event, Cultural Humility and Behavioral Health. This is a very timely and important conversation, a conversation that I'm hopeful will have providers asking themselves how they can bring cultural humility into their practice. How can they better serve people from all walks of life? How can they help people of all cultures? So I am excited about the work of the MAC. I want to thank the Multicultural Advisory Committee. They are passionate, they're dedicated, they are a great group of people who really have brought the MAC and the mission so much further. I especially want to thank Dr. Piggott and Adesua, who very graciously accepted this challenge a few years ago to help move the MAC forward. And it's under their leadership that we're able to offer this type of timely and important topic for discussion. So I look forward to this evening's conversation and what we're going to learn today. And I want to thank you all. So thank you.
Thank you, Anne-Marie. We really appreciate both of you being here for this important discussion. We put together a really fantastic bill of people to talk tonight based on their own personal experience and their expertise as professionals. So I'm just going to introduce our keynote speaker. We're so honored to have Dr. Will Carson here with us today. I'm going to give you a little bit of information, and I hope I didn't just murder your last name. Please, if I did, you can just let me know. But Dr. Will is a native of Long Island. He has an innate love for helping others. He's also known as Dr. Will, which is why I'm taking that liberty of calling him that. And he grew up assisting friends, family, and strangers alike through acts both big and small. He recognized joy and satisfaction in helping people around him. This seemed to be a perfect fit for him, so he chose to pursue a career as a psychologist. And he has a passion for counseling youth and adolescents. He attended University of Buffalo, where he earned his doctorate in psychology, and soon after that became a clinical psychologist in 2011. He's been proven in providing aid to the emotional healing of children, adolescents, and young adults. His previous work experience includes a private practice on Long Island for 7 years. He also worked with emotionally disturbed youth in residential care at Madonna Heights in Dix Hills. And he worked as a licensed psychologist at Creedmoor Psychiatric Center in Queens. He is currently at Stony Brook Renaissance School of Medicine, Department of Psychiatry and Behavioral Health. He's the director of Child and Adolescent Psychiatry Outpatient Services, providing care as a psychologist and teaching the next generation of providers in his role as a clinical assistant professor. His areas of practice include trauma-informed care, anxiety, depression, and externalizing disorders. Alongside his professional work, he truly enjoys spending time with his family and traveling. The doctor considers himself fortunate to have a career that neatly aligns with his life's work by producing high-quality, equitable care for all.
All right, thank you, Ariel. And thank you for everyone gathering here tonight. And I know lives have been very busy as of late, and so it's really sweet that we can get together and make time for a very, very important topic, one that's near and dear to my heart. So, and also I want to, before I begin, I want to make sure I give credit to the Suffolk County MAC, coming from the statewide Multicultural Advisory Committee where I serve as the chair. And it's really nice to know that the MAC be steadfast in the work they're doing. So I'm going to talk a little bit start off with a little bit about cultural humility, and then I'll move into bias in healthcare disparities. So I'm really excited that folks are continuing to talk about cultural humility. I know in the past we've often been using terms such as cultural awareness or cultural competence. And I think the big excitement for me is that we're no longer just giving a gold star to people that went to a training or had a good discussion or did a one-time process and feel like they've now met the standard for being culturally competent. And in particular, I'm going to be talking to our mental health care providers. And so as we move to cultural humility, we begin to understand a few things. So I'll start with a brief definition from Hook et al. And it's described as the ability to maintain an interpersonal stance that is other-oriented in relation to aspects of cultural identity that are most important to the other person. And so what we're doing now is that we're focusing more on process versus outcome. And the American Psychological Association has articles posted about cultural humility, and they break it down into three main tenets. The first one is a lifelong commitment to self-evaluation and self-critique. And so for that, I want to make sure that folks understand it's something that you're not going to be able to do it in one training. You're not going to be able to do it at one time. It's going to be an ongoing process. And it's one of constant self-reflection. And so someone earlier mentioned implicit bias, which we'll get into a little bit more in a minute. But really understanding the bias that you have and being willing to hear from other people, being willing to have conversations about it, and a constant thirst for knowledge. The second tenet is a desire to fix power imbalances. But you can't fix power imbalances if you don't know where they exist. A lot of times it's easy to understand the power imbalances that are affiliated with race and gender. But how often do we spend time talking about ability? How often do we spend time discussing the details and the nuances of socioeconomic status, nearby neighborhoods where you live, the benefits associated with growing up in a two-parent home, the benefits associated with growing up in a two-parent home, being a product of a heterosexual relationship. So these are different power structures that are in play that we don't often think about or talk about. And again, part of cultural humility is doing that work. And the third part is to develop partnerships with people and groups who advocate for others. And so after you've recognized what your power structures are and the power imbalances that you may be benefiting from or being disenfranchised by, it's important to participate in advocacy. And so again, we're not just focusing on a one-time thing, we're focusing on ongoing, lifelong commitments to this work. And so folks that join the multicultural advisory committees, folks that join their professional organizations, and then particularly go and seek out the subdivisions that are targeted towards closing healthcare disparities for specialized groups, are actually doing the work of cultural humility. Another aspect of the word humility that always stuck out to me was this acknowledgement that I don't know everything. And there's been studies that show that when mental health care providers in particular have some professional self-doubt, that they're able to capture more information and as a result, provide better care to their patients. And so, self-doubt is like, oh, why you should be confident about what you're doing and it's evidence-based and it's going to work. But if you only stick to the script, you end up losing and missing out on such quality information. And that's where that, again, cultural humility ties into, because now we're wanting to understand not just all the details about our patient, but how their families impacted their care, how their communities impacted their care, how the world continues to impact their care. And so when we start to take advantage of those opportunities to get further information, then we know we're doing the best we can by our patients. Implicit bias is something else that, again, is crucial to understand. And so it's defined as attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. With this, it's crucial to understand that implicit biases are pervasive yet malleable. Okay, so they can impact various views and perspectives of our lives, but they can also be changed. But they can't be changed if they're not challenged. And so the work that goes into that is, again, what we spoke about before, is commitment to fixing power imbalances and being willing to hear from one another. I would also encourage folks, if you have not University implicit bias tests. I take about 2 or 3 of those a year to continually check on myself and seeing where I need to grow. And a few times I've been surprised. A few times even more times I probably can admit that I've been disappointed. But for me, it's just giving me a charge of, okay, I got to do some more research on that population, or really I need to get around more of those folks so that I can understand their experience better. So, and in particular, I wanted just to touch base on cultural humility regarding race. Right? And I think it's hard to just say that, well, if I'm listening to people and I'm fully understanding their perspective, then I'm doing a good job. We as a collective in mental health, in the mental health field, we really have to do a deep dive on our practices and what we do on a regular basis, because a lot of our work is inherently working for the preferred population of white folks. And I know that it's not done by design, but I'll get into it in a little bit, but it's important that we take a look at where all of our founding folks of psychology, the schools of psychology that we follow, if you take a look at it, and you can test me if you want, because I Googled it even this morning, they're all white men. And it's okay that they're all white men, but it's also important to understand that we should look at some cultural adaptations to our behavioral approaches that we're still using today. And there's ways to do cognitive behavior therapy so that it's inclusive of more people and so that you can reach more people. One such example of that is affirmative cognitive behavioral therapy. And affirmative cognitive behavioral therapy is geared towards doing a psychotherapeutic approach for people that belong to the transgender population. And so what happens is once we start to do a culturally adaptive approach, in CBT, things are still the same. There's thoughts, we're changing thoughts to change feelings. But when we're taking that affirm approach, we would be searching for alternative explanations instead of just saying, oh, well, maybe your professor didn't call on you because they didn't see you. We would start to honor that patient's client resilience and say, you know what? You go to school every day knowing that the professor may not call on you, and that's pretty admirable. And so also, instead of universalizing the experience and saying, well, just about everybody may be dealing with that, or everybody may be getting stared at when they walk through the hall, you would say, you know what? It must be painful to have that experience. And so you can still get to address some of the things that the maladaptive thoughts as they arise, but you also want to be cautious that you're not invalidating someone's experience of discrimination when they're coming to you for support. The American Academy of Child and Adolescent Psychiatry, they put together some cultural competence parameters. And one of the things that they highlighted was that research is showing that people are brought to care, people of color, young people of color, are brought to care more often through involuntary services. So meaning through the juvenile justice system or child protective services as compared to their white counterparts. And so I think it's important to understand that when we have people experiencing mental health treatment in that way, where it feels forced, that it can lead back to times and there's racial and intergenerational trauma that folks have experienced over the course of generations and generations that makes it feel like they're being forced to do something again. And that leads to mistrust as well. And so, yes, we think that what we have to offer as mental health professionals is ideal and is going to work for folks, but it's important to understand that patient's experience, that they may be guarded. And speaking of being guarded, it's also important to understand that in some Asian cultures, that emotional suppression is valued, where folks don't verbalize their emotions. But a lot of our schools of thought in psychology are grounded in emotional expression. And so folks are encouraged to tell their providers how they're feeling, and if they don't, then they're considered to be guarded or not wanting to participate. At the same time, there was a study done by Soto in 2011 that states emotional suppression in Asian cultures, in particular, it was in Hong Kong and China, that those folks, there was no association with their emotional suppression and any psychological disorders. They were doing just. It's important that our Western ideals in the way that we practice behavioral medicine are inclusive of other people's perspectives and inclusive of understanding that people may get their emotions out in different ways, as opposed to the verbal that we're used to and the verbal that makes us feel comfortable. Also, just want to continue to talk about institutional discrimination. And I work directly with the Office of Mental Health, and so I know that they are actively working on these things. So I'm cautioning to say that they're not, I don't want to, when I get ready to say what I'm going to say, I'm not bashing them by any means. They're my friends and they're working on it, but they know they have work to do in terms of their leadership. They have and in terms of leadership, of course, all of the different layers in their structure. It's not good enough to just look at the overall numbers of workforce development and where everybody is. It's important to cut in half and look at the stratification of all the different layers, and then make a decision as to whether all of the different voices within the people that you're serving are being heard at different levels. With ongoing things related to, recognizing the importance of peer support, the notion that's going across OMH and other mental health systems has been that nothing about us without us. That needs to continue to be fed and led up to the front and to the top of the chain in the executive suite. Also, institutional discrimination, we have to do a better job of community outreach. Far often, we're worried about the patients and assuming that they should be coming to us in order to get their services. And if they don't do that, we have a problem. Or they have a problem and they're not doing what they have to do. They're not doing what they need to do, is the phrase that I hear so often. But when we bring things to people, in particular, there's been studies that show that bringing cognitive behavioral intervention for trauma in schools, the CBITS, when we bring that to the schools, when we bring the mental health treatment to the school where the kids are, they have a better results, especially for the young people of color. They show better outcomes versus going to an outpatient clinic. So that shows us that we need to continue to have outreach where people are, in the community, in their religious centers, in their schools, community clinics that are in their neighborhoods. That's all I have for now, but I believe I'm supposed to have some time for questions.
Thank you so much, Dr. Will. Definitely brought up some really interesting points. We're getting a lot of great feedback too in the chat. So yeah, we do have some question and answer time. We can actually unmute people if anybody has a direct question that they wanted to ask Dr. Will. If not, then we can go to our questions in the chat. Is there anybody that wanted to directly address a question with Dr. Will? If so, you can just put your hand up. Melissa. Okay. Anne-Marie, can you unmute Melissa? Or can she unmute herself? I'm not sure. Great. Melissa, you're on.
Okay. Hi, Dr. Will. So it was interesting when you had brought up the concept of, being communities of color and, into mental health therapy, and how a lot of times, these young adults and children are being brought almost against their will, if you'd like to say, just based on having a crisis and finally just being at a point where it's like, you know what, we've tried other, ways of dealing with this, but now we're going to take you into, the mental health realm or, different rehabilitation centers. My question to you is that, does that pertain to young adults? And if so, what are you doing as far as the younger children that culturally are being affected and are being taught as far as, we don't talk to the police, we don't discuss things outside the house. If you are upset, then, you can write that down somewhere in a notebook, but, I don't want to talk about it. So, we're not going to talk about it. How do you deal with that on a sense of younger children? Because the older adults, that's something where it's a learned behavior, and it's almost like a way you have to undo that. But how do we stop that from the beginning, where there are 10-year-olds being told, we don't discuss things like that, and you need to be quiet and go back to your room.
Yeah. It's interesting. It's a very good question. One of the things that comes to mind in terms of how to combat that is validation, right? And being able to say to the kid in front of you, listen, I understand that this stuff is difficult to talk about. And if you look at the cultural formulation interview when you're first meeting folks, so that it's not as intrusive to the person, but it says, hey, like, what does your family think about these things? And then you'll know. They say, well, they think that this is, what does your family think about your mental health problem? They think I don't have a problem. They think I need to just behave and listen to them. Okay, and then you get more information about how they feel. But what happens is you're starting to shift, so you'll know what you're up against earlier on, and you'll know what cultural dynamics you're up against earlier on. And then it's about validation. Say, yeah, it is tough. And to be able to say, listen, I know I can understand why your family thinks that way. I can understand why your family doesn't trust systems, because frankly, systems haven't always been kind to you, to families like yours. And that's hard to say, but it's true.
Thank you.
Mm-hmm.
We have another question on the chat. I'm gonna post it. Dr. Will, when you were on your road to becoming a practitioner, did you know that the field was so homogeneous, and did you face racial adversity from professors or colleagues?
I don't know that I recognized how homogeneous it was, and that would probably be because the field, so the field does have a lot of Caucasians in it, and in mental health. And there's studies that show it, the demographics, and also women. Interestingly, maybe because I wasn't as uncomfortable with that dynamic, because I've been in that dynamic, being born and raised on Long Island. If I think back to my training and when I was at the University of Buffalo, there was definitely room for people to grow in terms of understanding their implicit bias. But I do distinctly remember, and I think this is important too, when issues of culture and diversity came up, the whole room would look at me. And it's that singling out of like, oh, he'll know what to say, or he'll know what to answer. And I'll be honest with you, one day I was dozing off and something came up and everybody looked at me and I was like, look, I'm preoccupied. Someone else needs to answer. And so I think what I would like to see continue to happen is that we all lift the burden of understanding healthcare disparities, and we all lift the burden of challenging the preference for people in power, right? That we all take that on. So, and it's a personal commitment. So I myself have to do more work and a better job at making sure that the women that I work with get their voices heard, right? I need to do a better job to make sure that my physical space at my office is inclusive and inviting to people of the transgender population that don't want to go to a men or woman's room to use the toilet. So that's work that we all have to continue to do. But yes, that's my answer for that.
Thank you. Do we have time for another question? Dorothy Santana, are there any effective school and mental health provider collaborations on Long Island?
Well, I guess I'll give a plug for our programs here at Stony Brook. That there are. We do have contracts through Western Suffolk BOCES, where we work in their out of district placement schools. And we also have a school evaluation program through Eastern Suffolk BOCES. So any school in the Eastern Suffolk BOCES wing can, if they're having particular trouble with the student, can get a full-blown psychiatric evaluation. They're very thorough. And then also in our Western Suffolk BOCES in the out of district placement, we have a psychiatrist that's embedded as a consultant for that program. So we're going to continue to try to do more of that. More recently, we just had a couple of think tanks trying to work with schools or support them in trying to reopen their schools for this past fall. And so that's sparked some interest in us to have further collaboration in school districts.
Thank you very much. Ariel?
Thank you, Dr. Will. I think that was such valuable information, especially to end with that piece about, really integrating mental health into the school system. I think what we're seeing right now is such a vast change in the landscape of what our entire culture looks like. There's just going to be so many needs for our children and for our adults. Our transition in our behavioral health agency has been months, and access to care is something we're definitely concerned about for people statewide. So thank you so much. I also really appreciate your point about implicit bias being malleable, and how we can really we can change that, that it is possible to really examine ourselves and to work on those things, even though there may be very entrenched feelings and ideas about people from other cultures within us. So with that, we deeply appreciate you speaking today, and I'm going to introduce panelists. We have panelists from a number of different areas of expertise. So the first person I'm going to introduce is Alex Frisina. If Alex, you just want to give a wave, that would be great. Okay, Alex. Okay, Alex is from HALI, Hands Across Long Island, which is a peer-run organization. And at HALI, all of the leadership and staff identify with having lived experience and with receiving services in connection to mental health, substance use disorder, or disability-based services. He oversees departments focusing on advocacy, outreach, and self-help groups or mutual support groups. Prior to this position, he was 5 years as a regional youth partner for Youth Power. In his role there, he supported youth and young adults in knowing their rights and being involved within their communities. And we did ask people for a remarkable fact when they gave us their bio. So he let us know that hip hop is something that has saved his life. And as a hip hop artist, he's toured the US and Canada doing shows with the likes of Bone Thugs and Harmony, Onyx, Ja Rule, Mobb Deep, and more. So that's Alex. Thanks for joining us. Anne-Marie Montijo, if you want to give a little wave, she's one of our MAC co-chairs, and we appreciate her guidance. She joined the Mental Health and Wellness Association in fall of 2015 as the Deputy Director for Strategic Initiatives. She has over 30 years of experience in social work. Anne-Marie brings with her extensive experience in child and adolescent mental health as both a practitioner and an administrator. She provides executive leadership and manages multiple departments and programs within the Mental Health Association. Anne-Marie also provides clinical supervision and support for her staff at the Veterans Shelter, the Clinic Pros staff, and LMSWs. She's presented nationally and internationally on topics such as culture and self-harm, resiliency, as well as diversity, equity, and inclusion. She chairs the Diversity, Equity, Inclusion Committee at MHAW and has helped to develop a rich educational program for staff. Anne-Marie also wanted to let us know that she has extensive volunteer experience in cancer services and has worked with the Eye Cancer Foundation for 14 years, leading patient support services and organizing patient and family luncheons on Long Island in New York City. She's also volunteered for the Melanoma Research Foundation and is on the steering committee for Cure OM, and she's helped to spearhead many patient and caregiver symposiums across the country. She leads these groups at the symposiums for newly diagnosed patients with ocular melanoma and presents workshops on resiliency. She is also part of the host committee for the Wings of Hope Gala in New York City, a fundraising event for the Melanoma Research Foundation. She is a 14-year survivor of ocular melanoma, a very rare and terminal cancer. And when I read that, thank God we have you here with us, Anne-Marie. I really appreciate that you shared that with everybody. We have Robert Lettieri. If you want to just give a little wave to everybody. Hi, Robbie. How are you? I see Robbie up on your name here, so I'll call you Robbie. Robbie works at he's the Long Island Regional Youth Partner with Families Together in New York State. He's a leader that connects local youth groups, coordinates regional youth advocacy, and provides technical assistance and training on youth empowerment, youth-guided practice, and youth peer services. Currently, he's creating the first youth peer advocacy program to be implemented in Stony Brook's Children's Hospital for youth battling chronic illness and experiencing emotional distress. He recently published an article called Born to Stay, which was published in Lady Gaga's Born This Way Foundation in their new chapter, Channel Kindness. I was totally wowed by this. I love Lady Gaga. In his last role, Robbie coordinated and facilitated the first ever virtual training, which had 10 graduates who are now working in the field of peer support. His remarkable fact, Robbie battled a chronic illness growing up and experienced tics and seizures that would last for multiple hours on end and would force doctors to constantly place him into medically induced comas. When he was 16, he had a radical brain surgery that saved his life. Today, Robbie now has 2 batteries in his abdomen with wires that run up to his brain and are keeping him alive. Wow. Thanks for sharing that, Robbie. It's really you're doing amazing work. Faride Castillo, if you could just give a wave. Hi, Faride, how are you? Is the co-founder and director of Advocacy for Empowerment Collaborative of Long Island Incorporated, a trauma-focused agency. Ms. Castillo works within the community, court, and jail system to assess experienced trauma and address the needs of her assigned youth and families. Ms. Castillo works to reduce existing barriers encountered by immigrant youth and their families in their rehabilitation and reintegration process through therapeutic relationships, case management, and advocacy. For the last 7 years, Ms. Castillo has worked with immigrant youth and their families as they re-enter the community after being trafficked, detained, incarcerated, and/or separated. Ms. Castillo also assisted in forming and currently sits as a member of the federally funded Suffolk County Anti-Trafficking Initiative. This is a close collaboration of both non-governmental agencies and governmental agencies, victim service providers, educators, researchers, and other community stakeholders tasked with developing and implementing a coordinated community response to all forms of trafficking in Suffolk County, in addition to outreach and education. And last but certainly not least, we have Melissa Hawley. You can just give a wave to everybody, Melissa. And she's been a lifelong resident of Long Island since being adopted at the age of 18 months from Colombia, South America. She grew up with 14 other multicultural siblings. Melissa has firsthand experience when cultural humility is present and also when there is clearly an extreme lack. Present day, Melissa has worked for over 10 years in the human service field. She brings a wealth of knowledge concerning HIV, STD testing, HIV positive aftercare services, as well as linkage into substance use resources. In addition, she provides LGBTQ and B trainings on LGBT 101 and T101, which I'm assuming is transgender 101, cultural humility. Melissa's compassion lies within helping communities who do not receive as many resources and advocacy, specifically communities of color and the LGBTQ and B community. Melissa is also a part of the Multicultural Advisory Committee, and when she's not providing care coordination services, she enjoys spending time with her partner and also her 13-year-old son. So I know those were long bios, but I really wanted to give everybody the credit, for all the work that they're doing. So thank you, everybody, for joining us today. I'm really just excited for our panel. So the way that we're going to do this, because we have, about 6 different people that are going to be talking, is that we're going to just give out a question, and whoever has like the first kind of take on it that they'd like to put forward, please just unmute yourself and you can start talking. And then certainly everybody who's on the panel can just weigh in from there. I'll kind of keep the time We have a certain amount of time allotted for like each question, but we're going to have a more free-form discussion too. So we'll let it roll and see how it goes. All right. Okay. So obviously, Dr. Will talked a lot about what cultural humility means. When I was just doing my research, and I've done a lot of training and a lot of work on cultural humility, and I just always want to put out there too that the reason why I'm a part of the MAC is that I am a part of the LGBTQ community. I identify as queer. I've identified in a lot of different ways over many years, but this is my community, and it's very important to me that people are heard. So when cultural humility was presented to me, I really linked into it, and I'm just so proud to be a part of the Suffolk County MAC. So when I was looking up cultural humility, there was a lot of different definitions, and Dr. Will gave a great one. But the one that I found really also talked about honoring the beliefs, customs, and values of other people's cultures. So we wanted to put out the question to the panel. What does cultural humility mean to you? Unmute themselves, or if you just want to raise your hand. I don't know if we have them all muted at this point, Anne-Marie. So, hey, Robbie. So we'll unmute Robbie.
Hey, how are you? Am I muted?
Nope, you're good. We can hear you now.
All right, sweet. I guess so when I hear of cultural humility, I think more of cultural curiosity. And I remember when cultural competency was the main catchphrase, and I would think to myself, how can one be competent in somebody else's culture? But I think it's really important to remain open to learning how others view the world based on their individual experiences and how we are all raised on top of, the systematic oppression and systematic racism that is extremely prevalent in today's society. I believe that it's not only important to be open to learning about other people, but, as Dr. Will was expressing earlier, it's really important to keep ourselves in check. What triggers our thoughts and what triggers our emotions, what triggers what one can view as being an implicit bias, and if it is, then exactly that's what it is. So I think we can all benefit ourselves and society if we can approach cultural humility in the sense that everyone is fragile because we all are fragile on top of the fact that we are all strong at our core. But the most beneficial thing that I believe that we can do surrounding the topic of cultural humility is to challenge ourselves to break down and abolish any implicit biases that we have by learning what these thoughts are while they surface on our mind, as well as challenging how we can create more inclusive environments across the board.
Thanks. Yeah, I link into that too, in the sense that my journey with cultural humility also began with cultural competency. And I think at the beginning of that journey, I really believed that I could learn whatever I needed to learn to be able to deliver services to anybody that I met. And I had some hard, rude awakenings, along that path in situations where I didn't necessarily understand how to connect with a person in a way that honored, their cultural beliefs, their cultural customs. So I think that examining ourselves is so deeply important. And, Dr. Will talked about implicit bias and the Harvard implicit bias test, which I think that Anne-Marie popped into the chat too, if anybody's looking for that. And I love the idea too of taking that test multiple times in a year just to check ourselves. Do we have any other panelists that want to weigh in on what cultural humility really means to them?
So for
Alex?
me, yes, for me, it's funny because Robbie stole the words out of my mouth. I really think of cultural curiosity, but I think another step of it is when we're learning about a culture, then not assuming it on another person because they fit into what we perceive that culture is. So it's also keeping our eyes open that culture is different within every family, culture is different within every age range, and it's not once we learn about a culture, we now know everything about everyone who is part of that culture. So it's really exploring individually what that culture means to that person.
Yeah, that really emphasizes the humility piece of it, that we need to be willing to break down those barriers and those walls, and as a clinician, say like, I don't always know what's best for people. And to open up that idea that you don't need to listen to maybe a 5-hour training. What you need to listen to is the person who's in front of you, and really hear them instead of trying to dictate to them what's going to work for them in a treatment setting.
Absolutely. Ariel, just to add to that, I mean, Ibram Kendi's work really talks about, anti-racist work and really taking a look at the individual for who they are as an individual, and not speaking for their entire group or category, however you want to box them in, and the importance of seeing them as that individual, and not as the representative for all, as Dr. Will had referred to. We need to look at each and every person as an individual and ask them to share their experience. We've actually tried to eliminate the word competency from our vocabulary when it comes to any cultural and diversity, equity, and inclusion work, because there is no way for us to be competent.
Yeah.
I'm a believer in talking about the elephant in the living room, and if there is that cultural difference, racial difference, sexuality, whatever it might be, the clinician having that conversation and engaging in that conversation from the minute they walk into your office or you walk into to meet with someone as a practitioner. And that's the cultural formulation interview talks about that, and the need to ask, okay, if I appear to be a white practitioner and I am seeing a person of color, how is that going to affect our relationship, and putting that out in the open, because that opens up the dialogue immediately.
Yeah, I think that really validates the person. And certainly it is a difficult thing within us. Everybody, whenever we have discussions about race, and we're doing a lot of work within our organization right now. And really what we come back to is that like people are afraid to offend people. And what's most offensive to me is that you would not take the time to get to know me. So I think that that's an important way to think about it. Did we have any other panel members that wanted to weigh in? Hey, Melissa, on this particular question in regards to what is cultural humility to you?
I do. When I think of humility, one of the big things for myself, in my experience, is having the vulnerability. Growing up on Long Island, Anne-Marie mentioned it earlier, we're one of the most segregated, islands in the United States. And I'm not going to lie, for a long time, being adopted by Caucasian parents, there was a sense of, you don't understand how it is, because, my parents didn't know how to handle really, having, children of color. A lot of it, what they thought was going to be like, was exact opposite, or it was in death and they didn't know how to handle it. And that made me bitter. And a lot of times, when I would step into places of predominantly Caucasian centers, or I'm dealing with someone that, a therapist that doesn't understand my background, and I'm trying to sit there and, let them know like, hey, this is my experience, and, this is something I'm really struggling with, and they're not having the answers that I'm looking for. It's a vulnerable feeling, because now I poured myself to you. I'm telling you I'm upset. I'm walking around feeling like, a lot of times I have to be ready for an attack, and it may seem dramatic for others, but this is my experience, being a person of color and a woman. And I had to really step back and understand that, I have to be vulnerable, because that shows humility for myself, but it also gives that person the grace of understanding like, hey, like, I'm sharing things with you that I'm really not supposed to be sharing, not because, I was told not to, but for myself, it's making me vulnerable to you. And now things, and certain wounds, if you will, that, I have opened and about. So with, cultural humility, it's so important that we do step away from the competency word, because it's insulting. You don't ever get competent in someone else's, religion or ethnicity or culture. I never will. I'm Colombian Black, and I'm not competent in everything, and I'm Colombian and Black, So with that being said, I think, if people remember that it's also having to practice vulnerability, I think people would step away from being so much of, well, why are you not getting this? And, this is something you need to be working on and not me because I'm that, I'm the offended. And that's not always that case. Like we both can learn from each other, but we also can learn of, okay, this is my culture. What's your culture? Where did you come from to learn the things that you learned from? And that takes a lot of, for myself, it took a lot of the frustration out because I also understood that I understand that people not always are coming from backgrounds that are always so affirming, let alone, have, the cultural humility practices. So that's for me.
Yeah, I think we had, Frida, did you want to jump in?
Sure. So when I think about cultural humility, I focus a lot on the humility part. We have a very egocentric way of looking at things, especially like we can call it patriotism or nationalism or whatever you'd like to call it. But I think that we have like, and Dr. Will said it, like this very like Western idealistic way of approaching things. And we're a melting pot. We really are. I mean, even I'm in my name myself, I'm half Arab, half Latina, and Latina from Central America. My parents are from Nicaragua. I was born here. Understanding humility is understanding cultural humility is also understanding that individuals like myself are dealing with complexity of multiculturalism and intersectionality, and understanding that all these things are all coming together. Cultures from my different backgrounds and foods and like the things that I love, and also the things that sometimes are toxic to me, right? Because culture can be healing, but it could also be really damaging, right? I think it was Alex who said it so well. He said that we need to pay attention about how that culture, what that means to that individual, right? And pay attention to that and not just assume that, yes, their culture is beautiful, but how do they feel about it? Right. So coming from a Latin household, Latinx household, I was a woman, I was a girl. And so there was things that I couldn't do because I wasn't a man. And growing up in America where women had all these freedoms, we're like, wait, what do you mean? Right? Like I can do all these things. So for me, it was like that complexity of being someone at home and then being someone different outside of my home. And understanding what that looks like and what that feels like for individuals who are now seeking counseling and therapy with someone who might not have that complexity in their own background, to be able to, really remove that. Because when you think about humility, it's like that freedom of pride and arrogance, right? It's not thinking that you're better than me. It's coming at me from a human perspective, because even if you might not understand my background, you understand pain the same way I do, right? We understand shame and we understand emotion the same way. That in itself is universal. So I think that sometimes we focus so much on certain things that kind of removes the humanity of it all, right? And I think we need to get back to basics, and human connection is it for me. So when I think about, cultural humility, it really is that. And I also want to just end with this: believing one another. When someone says to you that they feel discriminated against, or they feel rejected, or that they can walk into a room like Melissa was saying and understand that there's already a discrimination that's occurring that she feels, believe that. I think that we have this really toxic relationship right now with like individuals who just refuse to believe us as people of color when we're saying, when we're screaming out loud, like, this is an issue for us. Please pay attention, please listen, please acknowledge it, right? That to me is cultural humility.
Yeah, thank you. Wow, that was such a powerful way to state it, that, people need to be believed. And, when they're not, like I've sat through a number of discussions now, just kind of focusing on, the kind of built up, rage that can lead to, over many decades. Like, how can you not feel rage when you are constantly being questioned about whether your experience is legitimate or not? And although I'm not a person of color, you know, as a person who identifies as queer and a person who has been in relationships with people who are gender nonconforming, you know, I've been placed in a number of situations where my experience, you know, as a femme appearing gay woman, you know, is not valued, or, you know, it's not recognized. And so while I do not speak to understanding, you know, the experience of people of color, I do speak to understanding that kind of feeling of shame, like you said before, and how that shame is universal. And as providers, you know, at some point or another, you have been through that, and so you know what it's like, and you can connect to that feeling. But thank you so much. Oh wow, such amazing, amazing.
Ariel, I just want to add something. You know, the burden of this discrimination and racism and all the isms have always been put on the individual, whether they're Black, they're brown, they're gay, they're straight. You know, anything that is against the norm, so to speak, and I say norm in quotation marks.
Oh no, Henry, cut out.
It's not their problem. This is the majority's problem. And they need to take it. They need to take the step and to address it, because they need to look at themselves. I mean, if you look at the Harvard implicit bias test, there are so many different tests that you can take regarding race, gender, religion, etc. And you know, if you don't fit into the dominant white male heterosexual stereotype, then you are looked at as other. And we need to take a look at that, because it hasn't worked for 400 years. You know, and we need to make changes. And I believe that, you know, through the MAC and through the commitments that we have, you know, we're going to make the changes. You know, we got to start small, and you start with yourself. You know, having been in an interracial same-sex relationship for over 30 years now, I mean, I've experienced stuff I would have never experienced had I been with a white male. You know, it opened my eyes. And as a very light-skinned Latina, I've been able to blend in. So, you know, you don't realize until you're faced with it. And that's why we need to, you know, whatever happens to, you know, walk in another man's shoes or person's shoes, to see what other people are experiencing. We need to believe people when they say that this is what's happening.
Yeah, I think that's an awesome segue to our next panel question too. So we really did want to ask people, and understandably, and we just want to put it out here too, is that, like, talking about these things can be, you know, reliving a trauma too. So let's be supportive, obviously, of one another. So our next panel question was asking people to discuss a cultural barrier that they felt that they had identified when seeking healthcare or behavioral healthcare, which to me should be integrated and one and the same, but in many situations are not. And what type of you know, lack of cultural knowledge or lack of sensitivity on the part of the provider was revealed as a part of that experience?
So for me, as I look back, it wasn't in the moment that I even noticed this was taking place. It was more as I got more in tune with everything that I was going through that I kind of look back and I'm like, that's really interesting. So when I started receiving mental health services and was struggling with depression, which now I see a lot of it was attached to feeling isolated as being a young Black male adopted by a white family in a very Caucasian area, and not really feeling like I fit in there, but also if I would go to a different community, not feeling like I fit in there because of how I was raised. And that led to a lot of self-questioning and self-doubt. And at no point in any of my therapies or hospitalizations was my race or where I was being brought up ever brought into the conversation. It was never discussed, even though it was something that throughout time I kind of realized was highly affecting me. And the fact that that was never even part of the equation to maybe get to the root of what was happening is kind of alarming. And then when it comes to my health, there's been times when I was younger that doctors refused to see me being adopted and not having full medical records of my biological parents. So the fear of me having something that had been passed down from my family and not wanting to see me based on that. So it's definitely been something that has affected both mental health and, like you said, it should be one all-inclusive mental health and health because it's one person and your well-being. But those are things that I've seen throughout my time.
Alex, I have a question for Alex. Do you think that that was just people being like, when they say, well, I don't see color, you know, like they were trying to treat you as, oh, we don't want to discriminate him. We don't want to make him feel like he doesn't belong. You know, we want to treat him as we treat everyone else, meaning everyone else who's white, right? So as I hear you talking, I'm wondering if people were meaning well and they just didn't see what was really affecting you. What do you think?
So I do think people meant well, but I also think they didn't necessarily weren't prepared to have the difficult discussion that is discussing race and my upbringing and where I was. So it was kind of trying to skirt around an issue that was pretty blatantly out there because they didn't want to have that difficult discussion with me.
Yeah. And that's why I think it's so important what we're all learning and what we want all the providers to learn. You know, that like you say, some things are so blatantly in front of you, but they need to be addressed. Thank you, Alex.
I want to piggyback with Alex because, you know, I also understand. You know, one of my big experiences when I was growing up, you know, because a lot of, and I'm sure everyone has life experiences, but specifically with being adopted, but not only that, but being adopted by, you know, Caucasian parents, there were, you know, situations for, in particular, I was being bullied in school. I had teachers basically embarrass me and my father because, you know, what is this white man doing picking up a little black girl? And we'd have to do the whole thing of, oh, well, this is my daughter, she's adopted. And that was embarrassing just because it was so intrusive for me. And it was also, why do I have to constantly, or my family has to constantly share with you to validate that I'm not being kidnapped? No, why am I following him around? And, you know, when that started happening, I did get, you know, into counseling and, you know, the therapist was not validating. And, you know, Anne-Marie again brought up a good point is, let's bring up to, you know, law talk. I do not have to give you burden of proof. When I was talking to my therapist a lot about what I was experiencing in school and, you know, even teachers, as far as comments they would make, you know, there was a sense of, well, are you sure that that really was the case? Like, maybe you're just sensitive, or, you know, maybe that wasn't it. Maybe, you know, she just didn't know how to properly, you know, talk to you, or maybe she just was curious and, you know, being adopted is beautiful. So really you should just be more open to discussing it. And it's just that sense of, and it still happens to this day where, you know, I actually stopped going to therapy because I could not relate to the therapist. You know, not only being a person of color, but I'm also gay. So now it's like, you know, I'm sure you have experiences, but the experience of being an LGBT individual in a relationship is different than hetero relationships. I mean, that's just what it is. So, I mean, my experience with the mental health system, it really tainted me. And I know that's something I do want to seek therapy eventually. But now it made me, you know, in a way, it made me better because I'm more diligent. I am asking questions of, do you have any person of color therapists? Are any of them LGBT affirming? Are they aware? Like, do they have education and the background training, you know, of LGBT stuff? But more importantly, have you dealt with people that have been adopted? Do you have, you know, practices with abandonment issues? Are you well versed on, you know, having, you know, individuals that don't want to seek out their birth parents? So it's one of those things where the mental health, you know, we've gone a long way, but we still have a lot more to come, because there's been times where the person I'm asking, like, hey, do you have a person of color therapist? it's almost like I insulted them by asking, because they can understand, well, why am I not enough? And I'm just putting words in their mouth because they didn't say that exactly, but the sense of, well, I'm a therapist and we can talk about it, and I'm sure you can. But there's such a special connection when you're able to sit there and have a therapist tell you, I know that feeling. I remember that. That hurt. I remember that. So it's one of those things with Alex also, it's the mental health component, the services for myself. It's been a struggle. And that's something like I hope, with cultural humility being, more in practice, we'll get to a better space.
Thank you, Melissa. Yes. It's a lot. It's a lot to tell us. And I appreciate you sharing everything that you just shared with us. Thank you. Anybody else that wants to weigh in on their experience, in a situation where they were seeking out behavioral health care or healthcare that became an access issue? Because obviously Melissa just very clearly showed, how much this can become an access issue for people when they're in need. And also thank you for speaking to really how you are empowering yourself to interview, therapists so that you know what you're getting into, because therapists can do a lot of damage to people if they're not properly prepared to work with them. And we know that.
So I'll share a little bit, not as myself seeking healthcare, but as someone who advocates to try to find, mental health services for many of my families. There's very few to limited to no access for language access. We just don't have it. And the waiting lists right now are ridiculous for families in need. So that's just one of the things that I see as a barrier for many of our families. Is if you don't speak English, you're just pretty much being put on a wait list at this point. There's also the cultural thing, right? Like I work with a lot of Latino immigrant families, and there's already this mistrust, right? Because many of them are fleeing governments and countries that are corrupt, or they've been through a lot of trauma themselves, and they haven't really been able to, access individuals or groups of people, or even an organization that they feel safe to really open up and begin to explore their healing with. That our communities, especially our Latino communities, aren't the ones to sit across from someone and tell them their life story. That's not how that works. We're the ones to get on the phone with our loved one or friend or family member and tell them our entire life story. And so for me, I base everything that I do on the relationship that I can create with my families. And, sometimes we have so much education, so much red tape, so much ethical boundary issues that also keeps us from, this professionalism keeps us from creating that bond with our families who are trying to really find services that make sense for them. And that's a cultural issue because, if I'm going to be seeking someone to tell my entire life story to, I want to feel like you're invested in me as much as I feel invested in you. And that's not how we do therapeutic services here. That's just not how we do it. I want to feel like you care about me. And I want to feel like I care about you before I tell you everything that's going on with me and my family. Because if not, if I can't trust you, first of all, I'm not going to tell anything to you. But second of all, it could become extremely dangerous if I do. If I don't trust you for myself and for my family, because I'm here undocumented, because I don't know the language, because I don't have access to things, right? And so when trying to establish this rapport, it really is about the relationship. We have to start to create more flexibility even within our own policies, within our organization, to really say, like, if we're going to be working with certain populations and groups of people, that we need to create that bond. Because let me tell you, it's that bond where I have seen can truly save a life. I always go back to, Maslow's hierarchy of needs. And for all of my psychology folks, like you guys understand, right? We are social creatures. We have been hardwired from the very beginning of creation to just be social, to feel and be wanted and be needed, and to have folks around us that we feel connected to. Connection is everything. And somewhere along the line, I think it just got lost. I don't know where, maybe in a textbook somewhere, I don't know. But that's the reality of what many of our families are facing. They don't want someone to diagnose it. They want someone to care about them enough to get through the hurdles of all the trauma that they've ever experienced, because that's really what we're talking about. And I'm going to finish with this. One of the barriers that existed for me, and I believe truly exists for many of our young people, is that we don't give language, we don't give context to what it means to have mental health issues. I suffer from depression and anxiety most of my life. I found out what it was when I was 22 years old. And I come from a long family line of individuals with mental health issues. I didn't know that. I thought they were crazy. I didn't know what the heck was going on with them, right? But here I am, right, in this family, completely and I didn't know how to put that in context or in words or have the language to express what was happening to me or how I felt. It wasn't until one of my coworkers, when I was 22 years old, pulled me aside and said, "Honey, I think you're depressed." I was like, "Oh my God, am I dying? What does that mean?" Because I had no idea what depression was. That was the first time in my life I have ever heard that. And I went to doctors, back to back doctors, trying to get them to diagnose me with something so that I felt like I could actually deal with what was happening with me, because there were days where I couldn't get out of bed. I had missed like 80 something days of school, and I had no idea why, because there was nothing physically wrong with me, and they were doing blood work. No one could tell me what the heck was happening to me. It wasn't until I was 22 years old and my coworker pulled me aside where I started what was happening to me. I had to Google it. Thank God for Google, right? But that was what put me on my path of dealing with everything that was going on. We are not giving language, and we're not giving context to what so many people are suffering with. They have no idea what's happening to them. And our young people are suffering because of that. I finish with that.
Oh, thank you. Yeah. And I identify, I'm also the daughter of a person who lives with a serious psychiatric illness. And I did not know in my family that mental illness existed. I knew, but I didn't know what it was, until I was in my early 20s as well. And how powerful it is to understand, that there's historical trauma, within my family. And because of that, it influenced, who I became, and it influenced my coming out process. It changed me as a person, and now obviously as a caretaker as well. So thank you so much for everything that you all just offered to this discussion. We wanted to give people some time at the end if they had questions for our panel members about their experience or what they've talked about, to put those forward. So we could encourage people, if they want to come off of mute and have a direct discussion, or people could put a question into the chat. We'll give like a minute for people to warm up and feel a little more comfortable, but this is obviously a very supportive group. So I think, whatever people bring forth, we're gonna do our best to back them up. And just while we're waiting for anybody to come forward with their question too, I just wanted to also just highlight what Dr. Will had said and what a couple of our panel members have said too about, the burden of understanding other people's cultures not being placed back on the people who are experiencing oppression or marginalization. That story, while I laughed when Dr. Will told it, everybody turns around, at one moment because they're talking about race, for the Black person within the class to highlight the experience. It's just so unfair. And it puts people on the spot. And I think we're all coming to a new understanding of what that looks like and how we, especially as white people, can avoid placing that burden upon the people of color that we work with and that we live with every day. Okay.
Ariel, this is Anne Marie. I think, as a provider, I think one of the ways that we're trying to tackle the issue is head on. Within MHAW, we've had a diversity committee for 5+ years, and really taking kind of the bull by the horns and saying, this is what we're doing. We're working on a diversity, equity, and inclusion statement. We've been doing education, on smaller scales with programs, on larger scales with, new hires and volunteers and interns. So it's really developing that and making it mandatory. I mean, we have to do HIPAA training. We have to do corporate compliance training. We have to do sexual harassment training. This is no different. And we are going to be, continuing and hopefully developing an entire curriculum. Because we have practitioners, and when we look around the room and you look within your, our clinics and whatnot, predominantly we're looking at Caucasian individuals who are providing services, to others. And, we need to do a better job, obviously, of hiring people of color, and also, encouraging people of color to get into this profession, because people want to talk to, a lot of times, somebody that looks like them and sounds like them. And we have to do, as an administrator, we have to do a better job of recruitment, retention, and helping people advance within our organizations.
We have a question. I think Marvin Smith just unmuted himself. Thank you.
Just to piggyback on what was just said, if 92% of the teachers on the island are white, how then do we encourage students of color to get engaged in psychological education and to become the psychologist when 92% of the teachers are white?
So I don't have an answer for that question. I think that would be best geared towards Dr. Will if we still have him, or if we have another provider.
It's one of those things that we've started to talk about even in medicine in general, and having conversations. The rates of Black men entering medical school are continuing to drop, and continuing to be show a lack of representation of the populations that are being served. So I think all fields, it's becoming of all fields to go. We talk about pipelines. A lot of pipelines start in undergraduate programs at best, but the reality is, by the time you start talking to juniors and seniors about their career path, it's a little bit too late, and nobody's going to spend extra time in college because it's not that much fun, or it's not worth all the money and expenses. So I think we have to do a better job in all careers and reaching down into high schools and middle schools and getting folks excited. We also, I've been using the term when they spoke a lot about herd immunity. We have to do a better job of normalizing mental health treatment in our communities and really using that knowledge or that notion of herd immunity for mental health in a variety of our communities where a psychologist or a social worker talking to you isn't as taboo. And it's just what everybody does. And in the worst case scenario, if there's 6 kids living on one block and 5 of them are in mental health treatment, that 6th kid is going to be understanding a new way of handling themselves and a new way of conducting their behavior and managing their emotions.
Thank you.
Thank you. This is Cheryl Williams. I just wanted to add to the question where 92% of the teachers on Long Island are white. We do have quite a few teachers that are of color, but they're unable to obtain jobs on Long Island. So they're teaching in the Bronx, they're teaching in Brooklyn, they're teaching other places. Because it's who you know, most times it's who you know, you have to have a connection in order to get that job. So what we have to do as a society is start changing the conversation, you know, educating folks on these are overqualified young people of color, and how come they're not being hired here in Long Island? So we have to influence the systems, start educating them on racism, institutional racism, and hopefully we can change that culture. But this conversation has to continue. It has to keep happening.
Agreed.
Agree.
Yeah. Olga, did you want to weigh in on anything else? We're nearing our closure time, so I just want to give our MAC, if we have anybody from the MAC that wanted to say anything else.
I think, you know, a little bit of what Fedi said, touching on the immigration. I mean, everyone's stories tonight from all different backgrounds, the LGBT, the African American, male perspective, everyone is just so unique. And I feel my only contribution would be the immigrant perspective, you know, coming from other countries and other cultures where when you start seeing a child displaying odd behaviors, it's like he just needs to be smacked, you know, he just needs to get whipped into shape. And that's what we do, you know. So one of the missions of the MAC is to open our eyes, to open people's eyes, to say, I always say, if you saw your kid with dragging a broken leg, would you tell him just try to walk straight, or would you take him to a professional, to a doctor? And I try to equate the same thing. If you're seeing those displays of anger or of depression, of isolation, you need to take him to a professional. That's the only way I can equate that and forget our taboos, our the way we grew up in our countries. I think that's why we are here. I'm talking about immigrants, because we have better access to things that maybe we didn't have in our country. So I want to thank everyone for opening their hearts and letting it all flow for the benefit of the rest of us who are learning.
Thank you, everyone.
Thank you. Yeah, and just in the minute we have to wrap up, I think, you know, really what we wanted to get out of this too, and we do have providers who are on the line, is that, you know, we want people to be speaking up within their organizations about the need to address these kinds of issues. And if you need further training, be engaged. And you can contact the Suffolk County MAC for information about, you know, where to get that type of guidance. And I know, you know, my own organization, we're doing a deep dive right now. We're evaluating our demographics, we're evaluating our recruitment strategies, we're evaluating our education. So, you know, progressive behavioral or health organizations right now are taking those steps. Now is the time. We have the momentum, we have, you know, the backing. So we want to get these things done. But on a more human level, we want to believe people, you know, when we're in our clinical settings, we want to really hear them, validate them, as opposed to trying to fit them into a treatment plan box. So I think that we had a really valuable discussion tonight, and we will probably have another in the near future. And we thank all of our panelists, and Dr. Will, thank you so much for being here. I think we did want to give, I don't know if we gave the email addresses for anybody that wanted to follow up with either Anne Marie or Adesoa, our co-chairs for our committee. And thanks for co-moderating, Olga. This was,
No,
it was
please,
great.
to everyone here, please join us. You can join us in the MAC. Come to our meetings. Well, now you don't have to come. You just have to log on to our meetings. And because we want to get more ideas of what we could be doing next. You know, we want to, this was great hearing from everyone. So we want to make sure that our next, you know, event or conversation, we have more input from you guys, from all of you. Join us.
And we meet the third Tuesday of every month at 9:30. Now
Yep.
it's virtually, so you don't have to drive anywhere.
Right. You can wear your slippers now. It's not a problem. All right. Thank you so much, everybody. I think that's everything, right, Anne Marie and Olga?
Okay.
I think we're
Yes.
And Adesoa and the MAC committee, thank you so much. It's been a pleasure being on it.
Have a great
Thank
night,
you.
everybody.
Thank you. Take care, everybody. Be
Bye-bye.
safe.